so many of the world risks remain invisible until it's too late. So as we stand in Davos, we've heard all about geopolitical pressures. What about climate pressures? What about shifting disease ecologies and supply chains vulnerabilities that are converging to create a new era of health insecurity? We're seeing heat waves fueling vector expansion. We're seeing biodiversity loss increases spillover. We're seeing floods that disrupt medicine supply and waste systems. But here's the hopeful part. Across countries, across continents, civil society, like you've heard from Benoit, is already demonstrating the power of integrated approaches. We're seeing researchers mapping resistance in humans, animals, and the environment. We're seeing local communities monitoring water quality. We're seeing environmental NGOs exposing pollution hotspots. And we're seeing youth action demanding more action on One Health, on antimicrobial resistant threats. So civil society has always been an accelerant, the force that turns scientific evidence that's been discussed so much here into political inevitability. And for One Health, this role is more important than ever. You will hear about a One Health Summit that will be happening in France in April. It's a plug for you, but you will see that we will have an opportunity for the world to elevate integrated surveillance and move from what can be seen as technocratic discussions to global priorities. So that's why we're here tonight. We're here not because we gather here in Davos to admire our challenges, but we are here to anticipate them. Everyone here is a leader. If you're here, you have agency. You are demonstrating leadership. So you can shape the architecture of resilience before crisis force our hand. So I will be joined by 4 impressive leaders, actually 3 because we have a little bit of an issue with one with timing, but 3 fabulous leaders who represent the essential levers of change. You will see and hear about evidence, financing, and scientific capability. And I will finally give you 2 numbers to guide our discussion. First one, by 2050, climate-driven health effects are projected to generate 2.5 trillion in economic losses. So just let that sink. But also contribute to 14.5 million more deaths, unnecessary deaths, globally. Large global health companies are also expected to face huge losses. So for those of you in the room that come from the private sector, you also have a big responsibility. Let us begin with this. I would like to call on stage all speakers. Professor Ramanan Lakshminarayan, you are the president of the One Health Trust, a senior research scholar at Princeton University, and your work has fundamentally shaped global understanding of antimicrobial resistance and the economics of infectious diseases. I will then introduce Peter Sens. You are the executive director of the Global Fund to Fight AIDS, Tuberculosis, and Malaria. But you also bring unparalleled experience in aligning political leadership, financing, and global health security. You've been the executive director of the Global Fund since 2018, and that is already impressive. But what people may not know is that you were the CEO of a large bank before and consulting experience as well. Dr. Liz Korsten, you are the president of the African Academy of Sciences and the co-director of the Center of Excellence in Food Security. You are one of the leading African voices in science, and you are also a pioneer in food safety, plant environmental health, and biosecurity. So you see, we have a star-studded panel, and we will start first with a little bit of setting the scene with you, Professor Lakshminarayan. So your work has shown for years that antimicrobial resistance and pandemic risks are systemic, not siloed. But as we are collectively trying to rethink One Health and its architecture? What does the evidence tell us about what do countries need? And what do countries need to prevent predictable crises? From surveillance to diagnostics to community stewardship, your work has touched on all these topics.
Thanks, Melina. Thanks to the Frontiers House for organizing this very timely discussion on One Health. So you all obviously know One Health, so I'm not going to try to explain that to you, but I'm just going to try to slightly give you a different perspective, which is that if you look at much of the improvements in human health, particularly in infectious diseases over the last 50 years, it's happened because of a combination of prevention, largely vaccines, but also things like water sanitation and so forth, and of treatment. So these could be siloed because you could actually just have a treatment for malaria or a treatment for HIV, and you could then deliver those through architectures like the Global Fund. And you could have impact because these could be dealt with in that kind of a siloed fashion, which is great. But this was not the world prior to 50 years ago. Prior to 50 years ago, it was much more of everyone being exposed to environmental risk. And in fact, the idea of zoonosis is the idea that the same pathogen could infect humans as well as animals. And we are now back in a world for a number of reasons. One, because of drug resistance, which is not just for bacterial infections, by the way. You know, we've had drug resistance for malaria, which has been a huge issue. We've got, obviously, for tuberculosis, which is also bacterium, drug resistance, and antiviral resistance occasionally. So we've had one, biology itself adapting to these control measures and saying, wait a minute, you can't keep doing this because we can adapt as well. The second is in terms of our own sort of behaviors with respect to deforestation, changes in land use over the last 50, 100 years, actually probably going back much earlier than that, which have also changed the calculus for risk in a significant way. And a third part of it is climate change, which is fundamentally changing which organisms are meeting which species. So organisms that would have never met certain species are now sort of coming in contact with them, including also with us, but we're only the end of that continuum. There's a lot of other sort of action that's already going on out there, and eventually it will come back to affect us. So these changes have been, by historic standards, pretty rapid in terms of these things changing, which is why we're now back in a world where just simply controlling things with these siloed approaches is not going to work beyond a certain point. Certainly there are many people who should have better access to malaria drugs or to HIV drugs or to vaccines and so forth, but that's not going to be sufficient. We're going to have to anticipate what these other threats are going to be. As you mentioned, the purpose of probably being in a place like this is to anticipate what those threats are. The second is to be aware of what they are as soon as they emerge and not much later. So a pair of remarkable papers that were published probably about 15, 20 years ago, one by Neil Ferguson at Imperial and then another group, showed that you could control avian influenza pandemic if you were able to detect the first case of human-to-human transmission within 2 weeks of it happening for the very first time. If you missed that window, you really couldn't control it because it was just too widespread. But you could use antivirals if you had that 2-week window, which means that we now have to detect in that period of time, which I would have thought would be impossible, but there's some technologies that are coming about, like wastewater surveillance, that we might be able to do that. The third is really with respect to response. And I think COVID has shown that you can actually respond quite fast, but COVID has also shown that your ability to access that response depends on which part of the world you live. So if you happen to be in a rich country, then you have access to that response. So then you're back in that kind of frame again. And last, just to conclude with antimicrobial resistance, which I think captures One Health in its full glory in such a clear way, because it does involve animal health. Animals themselves are suffering because of not being able to treat those infections. The fact that there are lots of effects that go in multiple directions. So for instance, vaccines for animals, for which we don't as a world pay much attention, is one of the best things we can do to tackle AMR globally, because vaccines for animals means that less antibiotics have to be used in animals, which means that there's less danger of spillover into humans. we are not thinking in those ways. We're thinking, Gavi, vaccines for humans, that protects human health. But if we protected animals from diseases, we actually would be protected ourselves. And that's just one example of the many ways in which if we were slightly more imaginative and just realize that our health depends on things that are beyond what we do for humans, we could probably get much more bang for the buck in terms of global health. Thank you.
Thank you so much. So we've heard from you that data and evidence can be the backbone of One Health, but we're seeing that financing and political prioritization are its muscle, so to speak. So Peter, this brings me to you, and you've heard the challenge put by Ramanand. So you and the Global Fund have deep experience in mobilizing countries around shared health priorities. What would it take for One Health and, as we've heard, integrated surveillance, combating antimicrobial resistance together to reach the level of political visibility and financing that you've been able to manage for HIV, TB, and malaria? That's a big challenge.
Wish I knew the answer to that question. Shame I have to answer it. Let me start by making one observation, which is I actually think that those of us in professional, academic, or political roles around this, have created part of the problem ourselves. If you go into communities which are in some of the poorest parts of the world, they know that their health is affected by environmental considerations. And they know that it isn't just a matter of taking a drug from the community health worker or what. And there is and I think one of the problems we have, they may not all know the modalities by which the water or the weather or the animals affect their health, but they accept that that is a reality they live with in many places. I think one of our problems is that if we don't understand a modality, we don't like to work with it. And so what we tend to do is operationalize things that we have an understanding of, and we ignore the things we don't have an understanding of. And that means we overstress some elements of solving the problem. And we kind of recognize that other things matter, but because we don't really have the science or whatever around some of it, we just say, well, we're going to simplify and ignore that. Now, I think one of the strengths of the One Health kind of mindset and approach is that it forces us to really think that through and say, actually, we should be looking at all these other considerations and factoring them into the way we do things, even if we don't fully understand all the modalities by which they interact with each other. The practical problem with that approach is it's quite hard. I mean, it is really genuinely difficult to operationalize. And I come from a business background. So you can ignore most of what I have to say. I'm neither a doctor nor a scientist. But I do know one thing that I learned from running a large bank and other business experiences is that if you make things too complicated, nothing works and nothing happens. And so one of the reasons, and I fully accept the shortcomings of siloed interventions, but they have actually delivered massive improvements in health. And partly because we've simplified the problem and said to execute against some of these simplified problems are still quite complex, but you can actually execute against them and you can make things happen. And I think one of the big challenges we have with the One Health approach is we need to identify particular sort of vectors of action, things we can do, really specific things. And I'm not saying they don't exist. I know they do exist. But really specific things we can do that can bring alive what we're talking about and also make change happen. Because to your point about mobilizing political and financial resources about this, the first thing is you have to have people recognize the problem. Mm-hmm. And the problem is people don't recognize the problem. I mean, the reality is AMR has been a communications nightmare, I would say. Relative to the scale of the problem, the amount of traction it has got has been incredibly disappointing. right? This is a problem with this is a pandemic threat with a probability of 1. It is going to happen. It is happening already, right? So it's a very high probability, and yet we are, I mean, Roman and I have talked about, we've singularly failed to mobilize significant resources in response to that. So first problem is you've got to make sure people understand that there is really a problem. The second is you've got to point to things that can be done that will make a difference. And this is where sometimes I think the complexity and breadth of the One Health discussion actually undermines the power of it, because there are so many different angles you can pick, and you end up confusing people. But this is where, and I know, talking about climate change now is not as popular as it was at the last Davos. But the reality is, you said, climate change is changing the dynamics by which all the different aspects, the environment, plant health, animal health, human health, interact with each other. And in doing that, it's kind of forcing a new look at all of this. And if I take a disease, the disease I'm most worried of, the ones we look at the moment about, is malaria. And malaria brings all of this into, you've got local environmental conditions, i.e. if your village is flooded, the chances are there'll be more mosquitoes. You've got all the dynamics of resistance. We've got both vector resistance, the mosquitoes becoming resistant to insecticides. We've got parasitical resistance. And it's, we know what the consequence is. We saw in the 1960s what happens when the malaria parasite becomes resistant to chloroquine. And we're going to see this with artemisinin as well. We're seeing it already. You've also got climate change having a very direct impact. The geography of malaria is changing. And also all these extreme weather events are making it much more difficult to manage malaria burden. And so malaria is a real test case of the thesis that you can't I don't think you can manage malaria without taking a kind of One Health approach. And there are some big unknowns. I mean, one of the things that we worry about is there are about 30 or 40 species of Anopheles mosquito that carry malaria. Climate change is changing the way the interspecies competition works in ways that you may understand, but I don't understand. But it appears to be doing things that are quite alarming, in that we got some species of mosquito, like Anopheles stevensi, which are very tolerant of very hot temperatures, seeming to do rather well. And that has some unfortunate things, because Anopheles stevensi, for example, because it tolerates hot temperatures better, bites more during the day, which means that bed nets aren't as effective. And it means that you're seeing surges of malaria in urban areas. So what we have in malaria right now is a real-time kind of lives at stake example of climate change kind of fueling and exacerbating the dynamics of One Health. And frankly, we're on the back foot, both in terms of understanding and in reaction to it. It's not like we're not doing anything. We are trying to respond to it. We launched last year a Climate and Health Catalytic Fund with support from Fondation S. I seem to remember some people were at Fondation S. And Gates. But I would argue that we're very much on the back foot in terms of the speed with which the dynamics of the disease are changing as a result of these things and our ability to respond to it. I'll stop.
Thank you, Peter. I think you've shown to us how complex it is, but that we also need very specific, you call them vectors of action for One Health. So let me turn to you, Dr. Korsten. So you are the president of the African Academy of Sciences, which sits really at the intersection of agriculture, environment, and human health. What are the most transferable African innovations or governance models that could accelerate One Health globally? You are actually operating it, and as Peter said, you are not waiting for any global organization to tell you that it is an issue. You are seeing it every day. So can you give us a little bit more context and nuances on this?
So let me just quickly take one step back, and I'm very glad you mentioned plant health. So people tend to cluster under environmental health, everything else. And in fact, we actually recognize food safety within that context. We even talk about soil health, and obviously water is so important, critical as a carrier for us. But plant health is often forgotten. So what's really happening in the continent is that we have created these networks, and we have several of these national platforms now. South Africa is a key player in this, but we also have Rwanda, Kenya, Uganda, and the CDC in Africa. And with the ARISE funding from the African Academy of Science, we are really funding these centers of excellence and now trying to connect these networks. Now, what is important about this is that, for instance, FAO has stepped in and helped us with developing training models for African scientists in risk assessment, because there's a significant shortage of that in the continent. And secondly, surveillance models and detection methods. So we are focusing a lot on developing fast, accurate detection methods that could be used in field. We also use this quite often with areas of border crossing between countries. I know Rwanda has set up these mobile biosecurity hubs where they actually monitor the movement of animals and plant material moving across these borders. What is unique about Africa is our wildlife reservoirs. So we have high density areas with biodiversity, and then you have big commercial farms, for instance, big cattle or poultry farming units. And then right next to that, you may have a totally informal sector with a few chickens and pigs running around. And yet next to it, you have the highest biosecurity farm with 6,000 piglets. And that's all mixed into one pot, and high population pressure, a need for food, and bushmeat being very popular. So you get that crossover between these different spaces. And this is where antimicrobial resistance becomes so important. Never mind the emerging and re-emerging zoonotic pathogens. But we find that with the antimicrobial resistance, we originally studied the impact of hospital effluent and, of course, these big poultry commercial farms, etc. And the impact on the river system is actually catastrophic. And what is even happening is it's impacting on our soil microbiomes. And now we find very high populations of multi-drug resistance in your plants, in plants or unplanted surfaces, keeping in mind the high percentage of fresh produce consumption. So now it goes straight back into your food system. And I think this caught everyone by surprise. There's been a lot of excellent publications in several parts of Africa where they could actually show that link from the farm, the feces into the water, on the soil, on crop, onto the plate. And I think that's quite unique. And that's something that I think is a global example of pulling the people together. And it was merely out of need. You know, we don't have so many labs. We have to share methods. And suddenly I can get a veterinary scientist working in my plant laboratory. So I think sharing methods, developing more rapid detection methods. And then another very interesting thing that's really happened in Africa is community observation. Pulling in those communities, living next to these wildlife reserves, and helping them with surveillance. They actually actively participate. And we actually get the veterinary scientists that will actually go out and work with these communities to help them. So I think for us, from a sort of a One Health, sustainable One Health system, we have to work together.
Thank you. Thank you so much, Liz. So we are starting to connect some of the pieces between global evidence, financing and political mobilization, and continental science leadership. But let's see how we can connect them. So I'll ask maybe 2-3 questions, and then we turn it to the audience. And I will ask you for rapid answers, if you don't mind. The first question is, you have all mentioned the role of surveillance, the importance of, we talked about it again, anticipating crisis. So how do we actually operationalize the connection between human, animal, and environmental surveillance? Is this something that you have been thinking about? And what is the one action that could be implemented in the next year?
So a very good example is where government actually got together with industry. So in our case, we've had the poultry industry, the Water Research Commission, and government, and our science foundations putting funding in, including Wellcome Trust and all. So now we have one big pot of funding. We have the whole group, and we follow one food system. We will follow one whole river, and from South Africa into Botswana. And we will be monitoring all activities next to the river and the communities. And suddenly you have your public health workers involved, your veterinary scientists, and we share not only the methods and the training in utilizing the methods for rapid, but we also share data. And I think this data sharing is another key point, because unless you unlock the different data pools, and particularly laboratory data, the more rapidly we can actually have early detection. And then it's not only about detection, of course, then control, etc. So key for surveillance and implementing it holistically.
Ramana?
I think I mentioned, I think wastewater environmental surveillance is probably the most it's the most promising technology, because I think we're only scratching the surface of what it can actually deliver for us in multiple ways. Recently, there was a paper which showed that if you could sequence from the toilets of aircraft flying into just 20 airports around the world, you'd be able to pick up any pandemic, fairly quickly. Just 20 airports.
Think about this when you fly tomorrow.
Yeah. Yeah. Use the toilet. So, but that gives us hope, which means that we're no longer reliant on health systems performing consistently in every country in the world. We can, leapfrog that entire thing to get to a place where we can identify pandemics, we can identify AMR. We now know measles can be picked up much earlier. We use this for COVID, but not just for humans, even for animals. We can use this to monitor animal diseases as well. And so I think wastewater environmental surveillance in multiple ways, whether coming out of hospital effluent, in public sewers, or like I said, in sort of aircraft, I think in the next 10 years we would have moved much further in having this be like a global, surveillance platform that all countries can really rely on. So that's the one thing
Yes,
that I would.
no, that's a great example. Peter, in your case, and I don't want to preempt your answer, but you mentioned the launch of this catalytic fund for climate and health. Is this helping countries, because they have one pot of money, rally behind one plan?
Well, I think that is a key part of it. I mean, listening to the kinds of things Lisa is talking about, the trouble is, in many parts of the world, those kind of cross-disciplinary efforts are the exception rather than the rule, and that's because the funding is fragmented. And one of the things we're trying to do with this Climate and Health Catalytic Fund is use the money to force collaboration, because that, and I'm a huge believer in wastewater surveillance, and we have funded a number of countries. Getting them to go beyond human health, though, is quite difficult.
Thank you. So this session focuses on civil society, and it's here in the title, the impetus from civil society to encourage and support government and industry actions on one, sustainable health. I would like to therefore ask you the question, how can civil society accelerate commitment, accountability on One Health, maybe the way like it was done for HIV, where we can draw from your experience, Peter. But of course, very important to have your perspective Professor Costa.
I'll be very quick. I'll just say, look, when you can make things human, stories about people and the impact on people, this is where you get political momentum, and civil society is the way you translate the story of individuals into political momentum. And that's why the HIV movement was so incredibly powerful. And the more we can do the same in this world, in this kind of context, I think we'll get traction.
Thank you.
I'll just pick AMR as an example. I think one of the things that Peter and I spent a fair bit of time on before this, what I'd call the great unraveling of the last year. Prior to that, we were hopeful that we could crack a particular problem, which is that a lot of people who die of drug-resistant pathogens simply didn't get the right drug. So that same child, if they were in Malawi, they might die of it, but if they were here in Switzerland, they wouldn't die because they would get the right antibiotic. So I think we should not underestimate even the ability of, what I'd call the siloed sort of approaches to delivering medicines to being able to solve these kinds of public health problems or One Health problems. So take MR, for instance. We are supposed to reduce the total amount of MR mortality by 10% compared to 2019 by 2030. That is the UN goal. We're not going to achieve that with vaccines. We're not going to achieve that with WASH. We're not going to achieve that with new antibiotics. We're only going to be able to achieve that if somehow we're able to get a pot of money to the Global Fund or somewhere to improve access to antibiotics. That's the only way. There is no other way. And I think here, civil society has a role to play in demanding that people get treated. We can't just use AMR as an excuse to say, oh, that's happening out there, it's happening in the environment, it's happening in animals, and therefore we have no agency or control over it. That is not an acceptable response, because there is a response, which is that if everyone in Africa had the same access to the antibiotics that other parts of the world do, there would simply not be the mortality from AMR in the entire world. And I think this is where we really need to not think of One Health as being this too complicated, insolvable kind of a problem. And I think very often we've done that, and therefore people sort of blank out when they see One Health, because they sort of see that's a complex system. We can't really do very much about it. Simply not true.
And I'll interject with one key figure, maybe, to say that in the next 10 years, antimicrobial resistance is expected to kill more than cancer. And I'm not sure that people realize that it's not, as Peter, you said, something that may happen. We are sure it's going to happen. And that is something that nobody's getting really prepared for.
Yeah, I want to take us back to COVID. Let's not forget, COVID taught us we should stand together, we can stand together, and together we can solve it. And I think that second message is that there is limited funding. Funding is shifting. And unless you can become part of transdisciplinary teams and work together to solve a bigger problem, you won't get access to really significant funding. And what I think is important is that we're pooling big funding now, so that there's a significant amount of funding. You can do a lot, but you can share your methods. You train your whole group so that you calibrate your methods. You can optimize your methods, and you can all use the same. And now suddenly data is interchangeable. We can now do better analysis, and we have better tools. You can do the whole microbiome shifts from the water all the way into the colon. So we can do much more than we could 10 years ago. It's empowered us. It has enabled us to actually work together. And I think it's taught us to co-publish, which previously it was really frowned upon. And now you get these co-authorships from people in different fields of study. And I think that's important. It's important messages. And I think that's taking us into the future. So how can we, as a community, together solve our problems?
So I think before we turn to the audience, I'd like to ask you for your one call to action for this One Health Summit that has been convened by the President of France, inviting all countries that want to support One Health. We will see how many countries will be in Lyon on the 7th of April. You will hear more from Benoit Miribel, the president of the One Sustainable Health Forum on plants there. But what is your one call to action? What do you want to see in the outcomes of this summit?
I would like to see a global statement and a global recognition for the contribution that scientists have done, can done, and will do, taking us into the future. And that's worth investing. Also to recognize that climate change is driving this at a significant speed, and that we have other tools. And I think AI is going to guide us on this, and it will revolutionize the way we do things.
Thank you.
I'd like to see a clear articulation of the top 5 actions that the world should immediately take and have that be funded, which have the greatest potential to either mitigate, report, as in through surveillance, or respond to AMR threats, but be very specific about what those 5 would be and have that be funded.
Thank you. There will be a big focus on AMR, so hopefully you will get to have a say on this.
He was very crafty. I mean, his one thing was about 5 things. Very crafty. Look, I'll borrow one of the antibiotic access thing. We're not going to get buy-in to stronger stewardship of antibiotics unless we solve the fundamental problem that a lot of people die without having it, because they don't have antibiotics. And so if we don't crack that nut, I don't see how we make progress on AMR. And if that would be one concrete thing we achieve, that would be a big deal.
Thank you very much.